Now, bullet number 3 is a key one. The Kenya government deliberately paid 75% of the UHC exchequer funds directly to a government body called the Kenya Medical Supply Agency, KEMSA. All right? That's something that we need to observe. And the counties, in the 4 counties, KEMSA had rolled out an online system for procurement. So it means even the clinical officer or the pharmacist at the root level 2 facility can actually order commodities. And that is what we are calling the drawing rights. So they could order them depending on what their needs were required. So systems were available and were put in place. So that is how they were to do it. As we said, facilities team ordered through the KEMSA web portal and deliveries were based on their needs. And give or take about 3 weeks lead period, and then you get your supplies. So my purpose is therefore community's perception regarding the supply of these commodities. What did we learn at the onset? Let me skip this, but look at the study populations. We have community members, women of reproductive age group, the elders, the elderly in the society, the youth. All these were residents living in the UHC in the counties. They were selected as part of this. David, tell me, how many focus group did we do? Remind me.
10 in each county.
10 in each county, that makes it 40?
Yes.
Yes. And then we have healthcare managers. This included the facility in charges, heads of departments, and there were how many?
We have a total of 85 IDIs.
Chair, this is just part of the presentation skills, so you can see they were part of the game. Yes, I'll skip all this because the ones who have gone before me have done a nice job. So here we are, going through. Community members, when you sum up all those 80 or so focus group discussions, the common lesson learned through is that essential medicines were available and had improved. So they're not only available, but had improved in the UHC. That is one of the quotes by the community health volunteers. They're even elderly. So that, we give them a clap for that. However, in the hard-to-reach areas, actually these are marginalized communities, remote side, they had a problem to even access. They said they had not received adequate drug supplies as an elderly did it. This was a unique one. I actually had to think through and through again. This is one of the counties that has high NCDs, non-communicable diseases. And diabetes is one of the leading conditions here. But somehow it happens that this particular place, when we went there were stockouts of some of the medication. And this is an IDI from one of the facilities that we saw, that we visited and held. So that's a community. People are saying, yes, although there's a little problem here and there, that is okay. So what are the health managers saying? First of all, again, they concur with the community, all right? That, yes, essential medicines had improved in the UHC, enough commodities were available. Some places, they also talked about having said, we have received sufficient supplies of medical commodities, including laboratory agents. Interesting. Up to 80% of their drug consignments. I think there is also somebody in the same place who said this is the highest they have ever received since independence. So they were happy about this. Here is another one. Kisumu, just down here. There was an increase in patients. My team members have talked about it. Consequently, that high money has translated to commodity shortage and at times mistrust in the healthcare systems and a bit of imminent stockout. If you can see, there's a time that there will be a shortage. As UHC is rolled out, the number of patients increased. So that was a fear. At this rate, I doubt that these drugs will be enough. Here is another healthcare service provider. Look at this. Increased patient flow crossing over from non-UHC pilot counties because they have been told of a service. Now they will cross over, all right? From our borders, we are used to getting this, and now we have gotten our drugs from chemists. Everybody is happy, or they are happy about this. The same thing when it comes to commodities like reagents, they were available but stretched. As much as the healthcare work was also stretched, also the reagents were they were stretched. And then some silent. There were some other emerging issues as we were doing the interviews. Madam Chair, some bad manners. Look, clinical practice. So some of the clinicians opted to skip first-line drugs and prescribing third-line drugs simply because they were available in the health facilities. They also requested all types of laboratory tests, irrespective whether they were necessary or not. There is that one. Immediately the UHC came, the prescribing habits changed. People were prescribed for drugs, people were prescribed for tests. So when we noticed, immediately our mind started thinking, how do we curb this monster that is cropping up? So although one thing is good, some bad manners is happening elsewhere. All right? Now, we have been pointing at this agency, this government agency. So we did an interview with them. We went, had an idea with them, and we asked them to tell us about their experience in those first 3 months. This is very interesting. That according to CHEMSA, sustainability of continuous supply of drugs and commodities is guided by the monitoring of the use of commodities, facility-based forecasting, and timely payments of outstanding bills. That is according to this manager. All right? They have also gone ahead and did some training. When it comes to commodity management, they are training, continuous training. They are training the facility pharmacists and others on good practices. So they are also defending themselves. So where is the issue now? What are some of the lessons that we want to learn? Yes. 4 take-home message. 1, consensus. The system is good, the commodities are available. It had removed costs, especially pharmaceutical cost, out-of-pocket expenditure for drugs had been removed, leading to increased demand, likelihood of over-prescription by clinicians, all right, because it is available. Number 4, a potential challenge to safeguard the population from out-of-pocket, that's again, which could be a threat to the UHC program. And going forward, Madam Chair, I think in the short term, the needs are met somehow based from that. But potentially, it may not be sufficient to meet long-term needs for the diverse patient groups. Policy actors in the house. This is our take-home message. Sustainability. It should be guided by monitoring consumption curves, facility-based costing, access to equitable distribution. And this is what my colleague has just said. Data for decision-making is required. So we need to keep quality data if we have to monitor this curve. And before, as I sit down, my take-home message after thinking through this is this. Systems are there. Maybe it's the processes that are weak. I leave you with that quote. Thank you.